Ultrasound Academy. It's an institution for dedicated ultrasound training located in Pimpri Chinchwad area in Pune. Hands-on training is given at KR Diagnostic Center, Bhakti Sonography Clinic and Sri Mauli Diagnostic Services LLP in PCMC area. Training is given by highly professional radiologists with more than 10 to 15 years of experience in the field of ultrasound. Training covers all aspects of ultrasound such as emergency, pediatric, gynecology, small part, OBS ultrasound, fetal medicine as well as invasive procedures under direct supervision of professionals. Personal level attention from faculties. Sufficient number of good quality ultrasound machines for training. Detailed teaching program with lecture series upon basic anatomy, scanning techniques, interesting cases, etc. Lectures from invited faculties, separate conference hall with AV facilities, complimentary FMM certification, separate WhatsApp group for academic students for academic discussion, and access to huge collection of well-documented ultrasound cases from archives of faculties.
On behalf of Ultrasound Academy, I would like to welcome you all to this beautiful webinar. Our motto of Ultrasound Academy is let's learn and improve together. It is not like a one-way teaching or one-way learning. It is like a symbiotic learning in which we will discuss the things and take our students with us so that at least they will achieve some optimum compatibility, right? And of course, we are dedicated to the passionate learning. Before we start, I would like to dedicate this presentation to one of the best teachers in the field of fetal ultrasound and fetal medicine, Dr. Ravi Chavi sir, who has inspired thousands of uh, imaging specialists all over the world in the fetal ultrasound. One thing, this quote I like very much, that once you stop the learning, you start dying. And this is so true that we experience this in our day-to-day life, not only in the field of academics, but in simple things in day-to-day life, we have to learn and improve ourselves, right? So as far as the ultrasound is concerned, the perfection is not achieved that easy. It is a combination of different things which we have to incorporate within us. It is proper technique, adequate time, practice, patience, and knowledge. And we have to improve ourselves slowly, right? So you have to be sincere students like this and chase the excellence so that the success will follow. So with this motivation, we will go to our fetal cardiac evaluation. We choose this theme because it is very close to our heart. Personally, I have evolved since my beginning of my career with this fetal heart. And so I would like to share how the things are evolved in last few years as we are growing. So these three videos of very common pathologies will show you how the imaging quality and diagnosis has evolved. Because over 2015, there was a muscular VSD which was picked up and the images were like this. In 2025, see such a beautiful image color presets now we can achieve in our machines, which increases the confidence of diagnosis. And of course, you have a volume probes now, so you can demonstrate the cardiac analysis, the volume format, and you can see the VSD as well as outlet and single view. So this is how it is evolving. So 2003 was the year when I joined my residency, and still the journey is going till to 2025. And the cardiac evaluation has evolved with different aspects like protocol of cardiac screening have changed a lot. Then technology and image quality, we are experiencing in day-to-day life, how the imaging is evolving. Then previously, we were having very limited knowledge about the fetal cardiac anomalies, right? How are the pathologies? How is the structurally anomaly seen? Then previously the learning resources were very limited. Now we have a lot of learning resources. So things has evolved. Then advancements in genetics, perinatal management, and treatment has evolved so that we can have a best outcome of the fetal cardiac anomaly in postnatal life as well. And of course, the expectations from parents are growing day-to-day life. They are expecting us to diagnose the anomalies as early as possible. So we will go through these headings one by one with the help of few simple examples. So protocols previously, when I was in residency or when I started my practice, the whole emphasis was just to see at the four chamber view. And at the most, we can document LVOT and RVOT if it is technically permissible. But that was all about the fetal cardiac anomalies. But eventually the all different bodies, they have improved, evolved their protocols, and now this is the latest guideline 2023 of ICO, which has insisted about all the detail sections along with the color Doppler with proper zoom, technical details, and mainly the emphasis is on diagnosing the outlet abnormalities uh, with very accuracy. So these are all available freely on the website. We can different websites and you can go through these. The protocols in early diagnosis have also evolved. If you diagnose you can diagnose the situs abnormality, axis abnormality by taking this image. Basic four images are compulsory when you do the NT scan for heart, that is fetal stomach, cardiac axis, two inlets and two outlets. So this will make us to at least suspect or diagnose the major cardiac anomaly as early as possible, provided you take these images very correctly, right? So make these images a part of your NT scan. Now, what we should follow or what I usually follow in my routine practice. I usually take one sweep from fetal abdomen to the superior mediastinum, which will give me a complete overview of fetal situs, gross cardiac anomaly, and the outlet abnormality. Along with that, I will take one sequence with proper color presets, with proper zoom, so that we will have good eyesight about how the color looks in the normal heart, so that it will become easy for us to diagnose the abnormalities very easily. Okay, you document the images systematically. Basic images, four chamber view, LVOT, three vessel view with RVOT. This should be documented along with the grayscale and proper color settings, right? So, and try to get the best possible images. It is not that you just take one sequence. Try to get best possible images like this once you have available good technology in hand, and document the things in the form of videos, right? So what are the sections I will document? I will document fetal abdomen, look for the situs, four chamber view for the gross chamber asymmetries, LVOT, RVOT. I will look carefully for the septo-aortic continuation. I will look carefully for the three vessel trachea view for vessel arrangement and sizes. And of course, last but not least is the confluence, which should be always on the left side. You have to trace the outlets till their confluence. In addition to that, I will document all four major valves like mitral valve, tricuspid valve, pulmonary valve, and aortic valve. In every case, try to document so that it will give you some practice, and when the abnormal case will come, it will be easy for us to document these pulse waveforms. And of course, one sequence with M mode. In first trimester, there are always few indirect markers. Like these are normal images. We usually document the ideal NT, I suppose. Then you document two inlets, two outlets with confluence on left side. You document tricuspid valve and ductus venosus. This has become a routine practice now so that we can pick up the abnormalities. Like here, there is a thick NT. Here there is single outlet which is very large, other outlet is small which is showing reversal of flow. There is a small LV, there is a tricuspid regurgitation in this image and reversal of flow in the ductus venosus. So all these things we will suggest or indicate that there is definitely some cardiac anomaly there and you have to follow these fetus carefully. Okay. So how the detection improved with changing protocols. So previously, these are my old cases when I started practice in 2006. This was the first, 2007. So I used to document and diagnose the cases mostly in the four chamber view and only in the image formats and look at the resolution. I have only one image that is a large AVSD. I don't know what were the associated abnormality in that case. This was the grossly abnormal four-chamber view, probably suggestive of cardiomyopathy. This was a 16-weeker case, 2012. There was a grossly dilated right atrium, right ventricle. So probably it was a case of Epstein's anomaly. And occasionally we used to diagnose outlet abnormalities like this overriding of vessel, then parallel outlets and ventriculoarterial discordance, which will be suggestive of TGA, right? But now in 2025, look at the images now. See, this is the linear probe image. How beautifully we try to document the complete spectrum of anomaly. Like here you can see single ventricular morphology as well as the outlet abnormality, which shows there is only a single outlet. So we should start documenting these anomalies as a complete spectrum and not the individual section. And of course, the color Doppler has improved so much that we can beautifully document the glamorous images like this. Okay, this is how the effect of protocols which we are following now. We have already seen this was 2012. At that time, there was no hard disk in machine. There was no facility to take the backup. We used to connect our computer to the machine and save all these videos on our computer. So this was a 2012 minor muscular VSD. Then this was 2015, beautifully documented muscular VSD. And now with advanced machines, with linear probes, we can confidently diagnose, see how beautifully. So this VSD has a two ends on the left side and one end on the, so these minute details we have now started documenting, right? We'll take this example of Fallows. See the complete spectrum, right? From four chamber view to outlet. Now we should know. See here in this case, four chamber view is fairly normal, equal size of ventricles, but there is a membranous VSD there, right? In outlet view, I don't see the pulmonary artery because it is very small and short. I can see the aortic arch which is going on the right side. This is SVC. And of course, there is a short and small pulmonary artery. So I know that this is classical Fallows. And not only the grayscale, we should also know how the flow pattern is. Why? Because if that Fallows has got a pulmonary artery, though which is small but showing forward flow, it will have better outcome. So that finding is very important for prognostication to the pediatric cardiologist, right? So three vessel trachea view has also got lot of importance nowadays. Many of the cardiac anomalies in the four chamber view will be reflected in the three vessel trachea view. Like here in this image, you can see small and short pulmonary artery and dilated aorta. So it suggests that it is a Fallows. Here, there are only two vessels. The central vessel, that is aortic arch, is lagging. There is no aortic. So it concludes that it is mostly a HLHS. Here, aortic arch is smaller, so probably it is interrupted aortic arch further or coarctation. Here I can see an extra vessel on left side. So 90% time I will be dealing with PLSVC, but sometimes it might be a ascending type of TAPVC there. Here in the confluence view, there is a small aortic arch. So that can be a coarctation. If in outlets with color Doppler, if one of the outlet showing reversal of flow, that means that that sided chamber is very small or valve is atretic. Like here, we can see forward flow in the aorta, but reversal of flow in the pulmonary artery. That means this is definitely a pulmonary atresia. Here, There is a dilated pulmonary artery and reversal of flow in the aortic arch. That means we are dealing with the HLHS. And here there is a U-shaped confluence, right? Instead of forming V on the left side, it is forming U-shaped confluence. So that is a right aortic arch. So all the anomalies, or by seeing at the three vessel view also, we can detect or indirectly get the idea about the main cardiac anomaly. So second part is technology and image quality. We will take this example 2007. See, single image AVSD. I don't have any idea about whether how were the pulmonary veins at that time, because we don't have eyesight. We didn't had eyesight at that time. But now, see, this is 18 weeker. Such a small AVSD we can diagnose because of the improved technology. And this is recent case. Third trimester, there was a classical atrioventricular septal defects with equal size of ventricles. So images have improved, right? Of course, and adding colors, color settings have so much improved our knowledge about how to set our machines. So this is classical. This was the Epstein's anomaly, which evolved late in the pregnancy with a significant amount of tricuspid regurgitation. With the linear probes and good color presets, we can diagnose now abnormal venous drainages. Like here, there is a this descending vein which is going down. We will be seeing many of the TAPCs in next presentation. So, and with the volume data, with color, we can classically and beautifully document all the cardiac anomalies. Like here, we can see the parallel outflows with ventricular-arterial discordance, which is a classical TGA, right? So definitely color has added the glamour, as well as our confidence of diagnosis has improved. We can implement it in early anomaly scans or NT scan also. Like we can now diagnose ARSA. Previously, I used to think that it is so difficult how we can diagnose, but now once you try documenting all the hearts in 12 weeks with color, you will definitely pick up the ARSA at the time of NT scan with volume data. This was a case of fetal hydrops with small left ventricle, small outlet, which was aorta, and after termination genetics, it turned out to be a Turner's in the case of hydrops. So coarctation, early diagnosis. And here, this is the transvaginal image of fetal heart. There is a single AV flow with red and blue, red and blue. That means that single AV valve is regurgitating. So gross abnormalities we can pick up at the time of ENT scan with TVS or high resolution probes, right? With 4D technology in hand, I usually try to document classical abnormalities with the volume probe. These are all rendered volumes, large VSD single AV flow. Here there is a smaller right ventricle with atretic tricuspid wall. Here there is a large VSD, two inlets, single ventricle. So this will give us a different perspective, right? Now, the knowledge has also improved. Previously, this was 2009. I picked this case at 27 weeks, and at that time, all the overriding vessels were used to be a phallus because we know only that pathology. But now I know when I see overriding vessel, I should document it properly to get a complete the spectrum. Here, like this is recent case. So once you see a overriding vessel, I have to look for the other vessel, what is happening to that vessel. And what is happening here, the overriding vessel is aorta, there is VSD, and this is smaller pulmonary artery, which is bifurcating. So I know that I am dealing with phallus and not no other abnormality, right? So now we know that overriding is not only phallus, but there can be a different pathologies. This is normal orientation, LVOT, RVOT. This is classical phallus, overriding of aorta, dilated aorta with outlet VSD, and smaller pulmonary artery. But other possibilities, yes, if the pulmonary artery is very small and showing reversal of flow, definitely we are dealing with the pulmonary atresia with VSD. If both the outlets are predominantly arising from right ventricle and the VSD is subpulmonic, we are dealing with DORV. And if I don't see other vessels, single outlet, dysplastic valve, and the pulmonary artery or branches arising from that common artery, I know that I am dealing with the common arterial trunk. So this is how the things have evolved now. These are the images of same examples. Phallus, smaller pulmonary artery, but forward flow. This is TGA with VSD, and this is DORV. Both outlets predominantly arising from right ventricle with smaller stenotic pulmonary artery, right? Genetic diagnosis is definitely now has become a part of our practice. Few anomalies of heart, we know that they are commonly associated with the genetics like AVSD with Downs, then outlet VSD, conotruncal abnormalities like Fallot's, DORV, aortic interruption. In such cases, we have to get the genetics done. Or when you see the VSD and those are associated with extra cardiac anomalies, we have to do at least counsel them about the genetics. Then of course we look for the soft markers in the heart like EIF, ARSA, TR in our day-to-day practice. So couple of examples I will share. This was a third trimester. See, look at this. This is classical balanced type of atrioventricular septal defect. This is axial view and this is coronal view. Large single AV valve in coronal view, fish mouth appearance. This fetus also had short femur and there was a
పిజ్జా
short.
పెట్టుకుంటున్నారా
And unfortunately,
పిజ్జా ఆర్డర్ చేస్తున్నారా
it turned out to be a full-term IUD. Still, we insisted them to get genetics done. And after the delivery, the chromosomal microarray turned out to be a trisomy 21. Okay, so AVSD turned out to be a trisomy 21. This was little bit difficult case technically, 18 weaker. Somehow I could document that there is a membranous VSD, small pulmonary artery, overriding of aorta, short pulmonary artery. So this was a Fallot's and they decided not to continue and the genetic turned out to be a positive for trisomy 18. So this was classical Fallot's. See Y configuration, short pulmonary artery. This fetus also had a agenesis of corpus callosum and partial Vermean agenesis. So turned out to be a trisomy 18. So these were two examples. Many of you might have seen many of the cases of positive genetics. Now, what is the advantage actually? Why we should emphasis on diagnosing the anomalies correctly and counsel them properly? See, there are few anomalies which have got very good prognosis. If we diagnose them in proper time and counsel them properly. Look at this example, 21 weaker. Four chamber was quite normal, outlets were normal, but I was not comfortable with this pulmonary vein confluence. There was not classical Mustach sign seen and there was a transverse vein behind the heart. So I definitely thought that this is going to be a anomalous pulmonary venous connection, but rest of the fetus was normal. So I just counseled them, asked them to meet the cardiologist. They also counseled them positively and parents were like very understanding and they decided to continue. So this was the follow-up case, 34 week. So fairly the chamber sizes were maintained, slight right dominance, increased retrocardiac space, and this was a descending type of TAPVC. So we had a ready diagnosis antenatally. So that was a very big advantage for us in this case. And baby shifted to the tertiary care center immediately after birth. Postnatal echo was done and which confirmed the diagnosis. They did the elective surgery and now that child is doing very well, now almost 5 to 6 years of age. So timely diagnosis antenatally, which has helped this child to undergo surgery at the right time before that abnormal venous connection gets tenosed or obstructed, right? So it was already obstructed. See the echo report, obstructed infracardiac TAPVC connecting to hepatic vein. There was a PDA, there was a moderate discrete coarctation. So all these things were tackled in time, right? This is how our approach should be, right? And of course, learning resources. Now Google has become like our fingertip. Everyone is searching on Google. There are beautiful books which have come up now. We should buy them and read. And of course, social media has day-to-day thousands of videos like our website. We are now uploading the videos. So learning resources are there. You have to just channelize yourself to learn. Okay, and the expectations are growing because the pregnancies have becoming precious. IVF, every child is precious now, and increase awareness, not only of our awareness, but patients' awareness also due to the Google. So, and sometimes there are over expectations. Relatives want us to diagnose ASD, PDA, small venous abnormalities, muscular VSD antenatally. Of course, few things are possible, but we should know our limitations. The few things we will not be able to diagnose antenatally. So we have to ensure that. And emphasis should be on the diagnosis as early as possible, and counseling, definitely we are improving now. Doing the ultrasound, giving the report, and just let them go is not the protocol. We have to tell them properly, describe them the abnormality in simple language, draw a simple diagram, explain them what is happening to their child, and in minor abnormalities, avoid creating panicky situation, right? Just reassure them properly, give time. Whenever there is a doubt, you take second opinion, and decision making should not be at the individual. You have to involve the multidisciplinary team, ask them to see the pediatric cardiologist, pediatrician, so that they should have like complete idea of economical and clinical things about the things. So, and let them help to come to the conclusion, right? So what next? So we have reached up to this, but the things are going to evolve. Like technology is going to evolve definitely. We will be diagnosing the abnormalities as early as possible. Genetics will become, it has already become a part of routine practice, but it will be compulsory for all the CSGs in coming days. Evolving 4D technologies, HD live, the realistic images, 3D models will be now become a reality to explain the patients very easily. You can document the cardiac anomalies in the volume data, and offline manipulation of the data will be easier, so that I can take the different opinions from different parts of world with the help of volume data. So this is how it is going to be an ongoing process. And take home message, we just have to keep upgrading with the changing protocols. Try to adjust yourself as early as possible with the newer technologies, and the best possible option should be planned. It is not like the diagnosis of cardiac anomaly is the end of the life. It is actually what I feel is the beginning of new life, because timely diagnosis is going to save the life. So ask them to deliver in a tertiary care unit. And that is all from my side. I will be always thankful to all my respected teachers for their blessings and teaching. And thank you so much all from all over who have joined this webinar. Thank you so much.
Thank you so much, sir, for giving valuable insight on this important topic. I hope your talk has paved way to understand the strategies to document a very good cardiac evaluation.